Yes, sir.
Thank you.
So it's 7 o'clock. Shall we start?
Yes, of course. Thank you.
Dr. Chatterjee, shall we start? Raghunath,
Yeah.
sir?
Yeah, please do. Go right ahead.
Yes, sir.
Please.
So good evening from ICMR-NITH, National Institute of Research in Tribal Health, Jabalpur. Good evening. This is a official and formal welcome to everyone, all the learned and distinguished speaker this evening, and then all the participants. On this evening of the World Sickle Cell Day, I warmly welcome all of you to this international webinar on sickle cell diseases, global perspective and Indian scenario. As the name suggests, the name of the webinar, we have experts from all over the world to enlighten us through this video conferencing. We have with us our Honorable Director General, ICMR and Secretary, Department of Health Research, Government of India. He was supposed to inaugurate this webinar, but unfortunately, due to his busy schedule on COVID, he will not be here. But in his place, Dr. Chatterjee, who is the head of the Division of Basic Medical Science, ICMR headquarters, he will deliver the inaugural address. Although I don't see Dr. Graham Sargent here, he will be joining a bit later. So he will also be here. He is from Sickle Cell Trust, Jamaica. I welcome him. Dr. Pradeep Patra, he is from Chhattisgarh Institute of Medical Sciences, Bilaspur. Dr. Umut Gurkan, who is from Case Comprehensive Cancer Center, Ohio, USA. Dr. Deepika Mohanty, who used to be the director of National Institute of Immunohematology in Mumbai, which is a ICMR institute. Now he is working in Apollo Hospital, Bhubaneswar. She is there. Dr. Dipti Jain from Government Medical College, Nagpur. Dr. Tulika Seth, who is from All India Institute of Medical Sciences in New Delhi. Dr. Alok Srivastav from CMC Vellore. Dr. Raj Subraman Sanmugam, he is my colleague from ICMR-NITHR Jabalpur. Mrs. Vinita Srivastav from National Health Mission, New Delhi. Our own Lieutenant General Dr. Raghunath. He is former dean from Armed Forces Medical College, Pune. He used to be the chairman of our scientific advisory committee for a very long time. So I welcome you all to this international webinar. Before we start, I would like to introduce our institute, which is one of the 27 research institutes from Indian Council of Medical Research, located in New Delhi. As many of you know, that Indian Council of Medical Research is a 110 years old medical research establishment, which is one of the oldest in the globe. And we are located in the central Indian region, and which is surrounded by tribal communities. We conduct research on health issues in Indian tribes, especially on malaria, tuberculosis, and sickle cell disease and other hemoglobin disorders. Today's event, organized by the Division of Genetic Disorder of this institute, by a very young scientist, Dr. Ravindra Kumar, whom you probably know by his name, and you have communicated with him. And he was very well guided and supported by the head of the division, Dr. Raj Subraman. I am not going to take more time because for the interest of time, we have to keep 10 minutes for every speaker. And then I hope that the deliberations of today's webinar will go a long way in understanding sickle cell disease in a much more detail in a global perspective, and also in Indian scenario, and we will learn, and probably we can contribute to this devastating disease, which is not only high mortality but with high morbidity. Thank you everyone for joining, and welcome you again from ICMR-NITHR Jabalpur. I now hand over to Dr. Ravindra Kumar, who will introduce the participant in a very briefly, and then we'll ask to present their talks. Thank you, everyone.
Thank you, Dr. Das, for a strong introduction for the webinar. Now I invite Dr. Governmental Involvement, scientist F, and from the Basic Medical Division of the ICMR-NITHR to deliver the inaugural webinar. Sir.
Not quite audible.
Not really audible.
I invite Dr. Governmental Involvement, scientist F, from the Basic Medical Division to deliver the inaugural address on the behalf of the Director General, ICMR-NITHR, for this particular event. Dr. Chatterjee, sir.
Good evening to all of you. I am Nabendu Chatterjee from the Division of Basic Medical Sciences, ICMR. Our DG and Secretary DHR, Professor Balaram Bhargava, could not attend this meeting due to an important meeting that's happening right now as we speak. So he has sent his best wishes for this international virtual seminar on the World Sickle Cell Day. On behalf of DG ICMR, I'd like to make some comments. This day, which is 19th June of every year, is recognized by the United Nations as World Sickle Cell Day for creating awareness about the sickle cell disease, or SCD, at national and international level. SCD is a human genetic disorder with high morbidity and mortality, exemplified by the fact that globally around 300,000 babies are born with this disease every year. India, along with Nigeria and Democratic Republic of Congo, share more than 50% of the global burden of SCD. In India, around 44,000 babies are born with SCD every year, with major disease burden in the scheduled tribes and scheduled caste population. The Honorable Prime Minister of India, Sri Narendra Modi ji, has shown deep concern and called for mitigation of the disease through early diagnosis, relevant therapeutic intervention, and awareness generation in vulnerable communities. As a part of Indian government's commitment, the Honorable Minister of Tribal Affairs, Sri Arjun Munda ji, has recently launched the Sickle Cell Disease Support Corner to bridge the gap between the patients and healthcare services in tribal areas. ICMR is to conduct research and provide necessary technical support to the state governments is early screening, training of healthcare professionals, and evidence-based novel intervention measures to combat SCD. Several ICMR institutes are located in different geographical regions of India are engaged in research in SCD and other hemoglobin disorders. To this extent, a dedicated satellite center for management and control of hemoglobinopathy is being established at Chandrapur, Maharashtra. Being a national institute conducting research in tribal health, which is unique of its kind in the country, one of the major mandates of ICMR-NITHR Jabalpur is to provide technical support and create trained manpower in the country that can help in mitigating SCD among tribal and other vulnerable populations. It is happy to know that ICMR-NITHR has taken a call in remembering the World Sickle Cell Day on this occasion. The learned speakers of this evening will definitely enlighten the audience, which will create curiosity and enthusiasm for research in SCD in devising better diagnostics, therapeutic intervention, and generic public awareness in managing this highly morbid genetic disorder in the country. Once again, I welcome all to this international virtual seminar on the World Sickle Cell Day on behalf of DG ICMR. Thank you.
Thank you, sir, for a nice introduction. And thank you so much, sir, for a nice introduction or giving a warm introduction of the sickle cell disease and what are they happening in India. And also now I would like to invite Dr. Pradeep Patra, sir. Pradeep Patra is sir here. Dr. Pradeep
Yes,
Patra.
hello.
Dr.
Yeah, I'm there.
Yeah. Dr. Pradeep
Yes, I'm there.
Patra is
Yes.
a doctor and come professor and head of the Department of Biochemistry in Chhattisgarh Institute of Medical Sciences, Bilaspur, India. And he has a great knowledge of sickle cell disease, and he started the Sickle Cell Institute in the Raipur, Chhattisgarh, and working on patients of the research on the sickle cell diseases. He has a tremendous experience and published several papers in international journals. Now I invite Dr. Patra sir to deliver his talk. Patra, is over to you.
May I request Dr. Patra to please start? May I request Dr. Patra to please start?
Not command line.
Dr. Patra, can you please unmute your mic? No.
Hello.
Yes, sir, please.
Yes, audible. I am audible, sir.
Yes, sir, you are.
Yeah, please. Good evening to all, sir. And thanks for inviting me. And I'm sorry for I'm in the remote place. I'm not able getting the internet connectivity. Just I'll share as tempo. My share is not, slide is not getting share and so many difficulty. But anyhow, I am getting now connected. Thanks for the invitation and the World Sickle Cell Day and the institutes of the ICMR is celebrating this international virtual meeting. I am very much grateful and for the invitation. As thanks for the invite. This is my introduction also. So as the sickle cell disorder, as you know, it is a most common and it is the first molecular genetic disorder known to the science, and there are a lot of inventions are there. Because you know that it is more than 100 years the sickle cell is known to the human. And so many molecular research has been identified, but still we are in the very backward state, you can say. And the sickle cell is very prevalent, as you know, in the backward people, like the tribal and the backward people. And in Chhattisgarh, I started work in 2007. Prior to that, when during my MBBS career, I started the sickle cell work in Burla Medical College with Dr. B.C. Kerr. He is, you know, all throughout the world, the B.C. Kerr is known, and with Dr. Graham Sargent. And when I was third year MBBS students, we joined hand and in the Burla Medical College started work. Since then, I have started this smaller work there And when I joined in the Raipur, the large scale work I started. I just
सर प्लीज अनम्यूट योरसेल्फ। सर आपका म्यूट हो गया है।
नहीं, वो भी नहीं है उनका, वो भी नहीं, नेटवर्क भी नहीं है, नेटवर्क भी ला लो। Dr. Patra, can you please unmute yourself?
yes, sir.
Please.
Yes, so that
Yeah.
it is, yeah. So then
Dr. Patra, probably there is some network issue. Even if you can close your video and then you can talk in audio also, there is no issue.
व्हाट्सएप कर दे रहे हैं फोटो खींच लो।
लाल है। सबको और में जाओ सब। I think there is some issue, network issue, as Dr. Patra also mentioned that he is now in a very remote place, and we can see that the bandwidth is very poor. So maybe when he will get the network and he will contact us, we will take him inside in the program when he will be available. So we can skip to the next speaker, Dr. Gurkan. I can see Dr. Gurkan. If Dr. Gurkan can start his presentation, please. And my colleague, Dr. Rabindra, will introduce Dr. Gurkan.
Dr. Gurkan is an associate professor in Department of Mechanical and Aerospace Engineering, Case School of Engineering and Case Comprehensive Center of the Case Western University, Ohio, USA. He has published several papers related to the diagnostic services of the sickle cell diseases and several patents. And 4 of these patents have been licensed for the commercial use. And now I hand over to the Gurkan sir for talking on the emerging diagnostic techniques for sickle cell diseases.
Thank you very much for the introduction. Can you see my screen?
Sir.
Yes, okay. Hi everyone, thank you for inviting me to speak at this World Sickle Cell Day event today. I would like to say that I have been to Jabalpur, Madhya Pradesh, NERD. I have visited NERD a few years ago, and it was a very good experience for me to see the sickle cell disease research capabilities and also the care that is provided for sickle cell disease, individuals with sickle cell disease over there. And I'm looking forward to visiting NERD facilities again. I would like to talk about the recent progress in diagnosis of sickle cell disease. And I'm an associate professor at Case Western University, and I also work with Hemex Health and Hemex DX of India. These companies have point of care diagnostics available for sickle cell disease, anemia, and malaria, which I will briefly talk about today. We are actually entering a new era in sickle cell disease in the context of global health and also cures that are being developed. If you have heard about the recent developments and initiatives such as the Novartis-Ghana public-private partnership on sickle cell disease has been a significant one. because this initiative aims to screen for sickle cell disease in the whole country and provide hydroxyurea, an affordable and available treatment for sickle cell disease. Another important initiative in the United States is the Cure Sickle Cell Initiative. And the purpose of this initiative is to bring together researchers, clinicians, patients, their families, all the stakeholders to work on developing cures for sickle cell disease. And my group and I am actually a part of this Cure Sickle Cell Initiative, and we work on developing diagnostic methods to screen for sickle cell disease, as well as to evaluate the safety and efficacy of cures, to assess, for example, how the red blood cells are changing after a cure and how effective the cure is for the patient. Another important initiative is the Bill and Melinda Gates Foundation and NIH joining forces on developing accessible cures for HIV and sickle cell disease. And then another recent one is focused on, again, by NIH here in the US, focused on developing multiplexed non-invasive diagnostic technologies for sickle cell disease, anemia, and malaria. As you know, anemia and hemoglobin variant tests, hemoglobin tests are very important tests in this context. And according to World Health Organization, WHO, anemia testing is an essential diagnostic capability that is very important for all the countries actually in the world. And hemoglobin variant testing, specifically electrophoresis, is also in the WHO essential list of diagnostics for sickle cell disease. This is a picture from a typical hematology lab in Kano, Nigeria. As you can see, there is an HemoQ that is a point-of-care test for anemia, and there's an electrophoresis setup for hemoglobin testing. And this is pretty typical in many labs that I have seen in India or in Africa, in Southeast Asia, here in the United States as well. This is a pretty typical lab setup that includes an electrophoresis system. In some places, there's also HPLC, which I'll talk about, but this is pretty typical. So our goal was to combine these important diagnostics into one platform and make them easier to use, affordable, portable, much more suitable for point-of-care use. If you look at the different types of electrophoresis testing systems, hemoglobin testing systems that are available out there, they go from lower cost, lower complexity to very high cost and very high complexity on the right-hand side. There are point-of-care tests, for example, the turbidity, Sickle Dex turbidity type of tests. And more recently, lateral flow dipstick tests have been developed for that can test for ASC, for example, hemoglobin's ASC. The most common type is the one in the middle, hemoglobin electrophoresis, IEF-based, isoelectric focusing based, or cellulosic-based. HPLC is available in high complexity labs, and genetic testing is the gold standard, as you know, DNA PCR-based tests for identifying the sickle mutations. It is important to note that most of these tests, especially on the right-hand side, electrophoresis, HPLC, and genetic testing, are very expensive, not available in many places in rural areas, and point-of-care tests that can do quantitative, accurate diagnosis of hemoglobin variants would be very important. So this is what we focused on. We wanted to take all these capabilities and then put them into a single platform that would give you reliable, accurate, accessible, quantitative hemoglobin results, as well as hemoglobin level and anemia testing and malaria. So we wanted to achieve all these tests on one platform for widespread use. So here, our goal was to start with the cellulosic state electrophoresis, which is the most common type, and it is many people are familiar with this in Africa, in India, in many places here in the United States as well. Some of the challenges of this technique is the large buffer volume that is used, and there is a post-assay staining that needs to be done, and it typically takes 20 to 30 minutes of runtime. You need power, lab infrastructure, and trained personnel. We wanted to have a version of this electrophoresis system that integrates all the components. It can be used by anyone, anywhere, without any training. We also wanted to achieve automated machine learning, artificial intelligence-based analysis of the results, so that the user doesn't need to do any interpretation. The machine does all the interpretation. It gives you the diagnostic result. And also anemia testing. So we wanted to have anemia testing on the same platform, total hemoglobin level. So if you think about it, the cellulosic hemoglobin electrophoresis would give you the bands, and the user would interpret the results. The presence of A, F, S bands, their relative intensity, and then come up with a diagnosis. For example, number 4 here is a trait sample, which the user needs to recognize. But imagine if we can actually have an automated result that looks like this on the right-hand side. This is the result that the Gazelle system would display. It would show you the S percentage, 42% in this case, A percentage, 58% in this case, and it would tell you it is likely sickle cell trait. It would give you the phenotype as AS based on the amount of hemoglobin types. A is more than S, so it shows you AS. And then it also gives you notifications such as transfusion can impact results. Because, you know, if you think about it, if you have an SS person, a sickle cell disease person who's transfused, you might actually observe some A in their blood samples. So it also reminds the user that transfusion or other things, you know, this is just one example, but there are many other things that the software, the device basically makes note of. So our goal was to achieve an automated and much faster, much more easier version of electrophoresis. And this is how the electrophoresis test looks as it runs. We also integrated a blue marker, which wasn't present in the original assay. And it also, the blue marker lets you confirm that the test is running for accuracy. And we also use the blue marker to quantify the total hemoglobin level. And then, for example, here in this case, you would see 2 bands, which would correspond to AS, a trait sample. Another aspect of the technology that we have achieved is it is battery operated, so it is portable and battery operated. It can be charged using micro USB, and on one charge, it can run tests all day. It can store thousands of test results in it. It has a local memory, and it also has Wi-Fi connectivity, so it can upload the results to a cloud. Cloud-based data storage is becoming very important everywhere in the world for managing the data and also making it more accessible to caregivers, hospital administrators, nurses, patients, even through mobile phones and tablets and so on. And this machine can do all of those things. It also has a wireless report printing feature. It can report a paper report to a printer that it can wirelessly connect to. And the test results, depending on the test, malaria, anemia, sickle cell disease, vary between 1 minute, 3 minutes, 8 minutes. For example, malaria test is only 1 minute, anemia test is about 3 minutes, and hemoglobin electrophoresis, total hemoglobin electrophoresis is about 8 minutes. It has very high accuracy. Another important aspect of this device is it's actually a platform technology. And we are actually adding new test capabilities almost every month. So far we have achieved sickle cell disease and trait regulatory approval. So this is regulatory approved and commercially available in India right now. Malaria is also approved and it is commercially available. Recently, we have added newborn testing capability, so the test would work for the newborns as well. We are working on adding thalassemia, anemia, and A1C testing capabilities on the electrophoresis side. And on the malaria testing side, we are also working on adding anemia and immunoassays. So you can actually get the anemia state and malaria result in the same test. So we are trying to combine these important tests that make sense to have together. We also achieved COVID-19 diagnostics recently, proof of concept. It's not commercially available or regulatory approved yet. And we are working on adding metabolic serum protein electrophoresis that you might be familiar with, alpha beta globulins for metabolic tests, and is for also for certain cancer diagnostics. The technology, the capability of the technology, malaria, hemoglobin variant, and others have been tested extensively in the world, in many places, as you can see here. In India, in Africa, Southeast Asia, South America, in the United States. The field tests included testing over 6,000 patients on different capabilities, and the data was also used for regulatory approvals. And NIRD has played a really important role in our earliest, one of the earliest field studies that we did in India was at NIRD actually. As I said, this technology is available in India through HemXDX, hemoglobin variant test, and you can actually see the user data sheet here translated to the local language. So it is actually now available in many different languages, and it also received state government orders recently, and it is also in the government e-marketplace, and there is actually quite a bit of social media interest and ads on the technology, so it is quite accessible. It is used in many places. One important aspect that I would like to highlight is the capability of uploading the data to the cloud. So this is one of the first fully connected point of care technology, diagnostic technology platforms that is out there. So after the test is done, we can actually uniquely identify the data to the patient, upload it to the cloud using the mobile networks or wireless networks, and then the results can be accessible through mobile apps or other electronic medical record systems. And this aspect of the technology actually won the Vodafone America's Wireless Innovation Project Award in 2018, and this was also supported by NIH here in the development phase. I would like to emphasize that this has been a really teamwork, and I would like to highlight the leadership of the HemX Health. I'm actually a researcher. I'm the one who invented the technology. I helped the company develop new products and then do more research. But the rest of the team here made the product possible. I would like to also highlight Purnima Kumar, who is our managing director in India, HemXDX India. By the way, this technology was designed with Tata Elixir of India by engineers in India, and it was brought to this stage with significant contributions from physicians, engineers, scientists in India. And the product is now also manufactured in India. It's made in India product, and it's exported to Africa and other places from India. So we are also very proud of that. These are all the support that we have received over the years, companies, organizations that supported the work. You can see the Tata Elixir here. And that's all I have for today's presentation. Thank you very much for your attention, and I would be happy to answer any questions. Thank you.
Thank you, Dr. Gurkan, for a nice presentation. Dr. Gurkan has told us the various aspects of the diagnosis of this sickle cell disease, from solubility test or point of care devices to HPLC advanced techniques. What is the cost involved, and what is the need for the sickle cell disease diagnostics in the remote areas. And I thanks once again Dr. Gurkan for giving us time for this wonderful talk. Now I invite Dr. Deepika Mohanty, ma'am. Dr. Deepika Mohanty is a former director for ICMR National Institute of Immunohematology, and a consultant and hematologist, and director of the laboratories at Apollo Hospitals, Bhubaneswar. She has published more than 400 publications and book chapters for the working hemoglobinopathy. It is credibility that or its enthusiasm that for the work she received several awards, and now I've been talking today. Over to you, ma'am, for
your talk.
talk. And she is talking on currently on nitric oxide inhalation therapy for vaso-occlusive crisis and acute chest syndrome in sickle cell disease.
Good evening. Good evening to all and good morning to some. Now, I'm very happy that Jabalpur is doing the Sickle Cell Day celebration or observing that. And also, I could gather that Chandrapur Institute also is taking a step which will be managed by National Institute of Immunohematology. And this was our desire for the last 20 years. When I was director, I moved this for the Chandrapur. But anyway, I'm happy for that. And also, I would like to thank the director of our ICMR Tribal Research Center, Dr. Das, and also Dr. Ravindra, for giving me this opportunity to speak here and also giving a nice introduction. This is a very small work which I have done in Bhubaneswar when I am here in Apollo Hospital, because there are a lot of cases of sickle cell anemia which come from the western part of our state, that is Orissa. So I'll be telling my experience with a simple procedure, and also to begin with, I will say that as opposed to previous belief that
Please,
the sickle cell anemia is not morbid. The severity of the sickle cell anemia in India is not there. But now we have seen that the severity varies from place to place, especially in the central part of India. That is where the Jabalpur is, and also in Maharashtra. So I now start on the particular topic which has.
Ma'am, may I request you to please put in the presentation mode?
Yeah, I'll just do that.
Please, ma'am.
So I'll be speaking on the what is nitric oxide therapy in the vaso-occlusive crisis, as well as the acute chest syndrome which we come across. And about pure pain is a problem of the sickle cell anemia cases. Anemia is not that much, but pain is a problem. And it is mostly due to the vaso-occlusive crisis. And this vaso-occlusive crisis is a common painful complication of sickle cell disease in this part of the state, that is the western part. They come, and it is present in about 85% of cases who report it during their acute crisis. Acute episodes of severe pain are the primary reason that they come from western part to Bhubaneswar. Vaso-occlusion is responsible for a wide variety of clinical complications, as we know, in sickle cell disease, including pain syndrome, stroke, leg ulcers, spontaneous abortion, and renal insufficiency. So, this made us.
Ma'am, sorry to
Let's see
disturb
what
you.
is.
Ma'am, please put in the slideshow mode.
Slideshow mode.
From slideshow.
Put in.
Yeah. Yes. on current slide.
Okay, so let's
Yes.
see what is the pathophysiology of the vaso-occlusive crisis before we go for that. This is also very well known, and the vaso-occlusive crisis is initiated and sustained by interaction among sickle cells, endothelial cells, and plasma constituents. The acute pain is caused by ischemic tissue injury resulting from occlusion of microvascular beds by sickled RBC during an acute crisis. That is what we have shown here. The chronic pain also occurs, and that may be due to the bones and joints, sometimes the visceral organs are repeated attack. Obstruction of blood flow is the main one, and this produces the hypoxemia and acidosis, creating a recurrent pattern of further sickling, tissue injury, and pain. So this is what this cartoon shows, that how the main important thing is the interaction between the endothelial cell and the sickle cell, and here the yes, I think there are a lot of other constituents of blood which are involved in that. That it starts with RBC, but the leukocytes as well as the uh, platelets, they also take part. Now, let's see what is the natural history of this vaso-occlusive crisis which happens in pain. This is about 3 to 10 episodes which happens yearly, resolves within 5 to 7 days. A severe crisis may cause pain that persists for weeks and months. The frequency, severity, location, and duration can vary inconsiderably. And usually we have seen that during the rainy season as well as in the winter, this becomes much more. Disease severity is thought to depend on a complex interaction of genetics, rheologic, and hematologic factors, as well as microvascular and endothelial factors. The psychological, behavioral, and cultural profile also influences this perception of pain and their ability to work. The approach to pain control must include measures to treat acute pain crises, prevent future vaso-occlusive crises, and manage long-term sequelae of chronic pain that can result from multiple recurrent bony infarcts. Now, we do some lab investigation also to find out whether the patient is having chest syndrome, whether the patient is having some the kidney involvement, and so we do the hemogram, urine analysis, chest radiograph, culture of the blood, sputum, and urine, and the electrolytes and ABG. This is what is the must. So usually management, Dr. Kulika also will be speaking, so I won't go to the details, but abroad in USA and in other countries, they do the opioid analgesic institution, rest, reassurance, adequate hydration. These are important, but I will not go to the details of it, but I will tell us our work which we have done here for the pain relief. What we do is we have a visual analog scale, the verbal categorical scale, and the pain relief scale. The workup is done with the history, that is the history of pain, how long it is, and what other symptoms the patient is having. The fever is present in about 85% of these cases in uncomplicated vaso-occlusive crisis. Severe pain warrants hospitalization. So these patients who come from usually Western Plat, that is Sambalpur, Balangir, Sundargarh, they come to Bhubaneswar because we created this pain crisis treatment. And the differential diagnosis in these cases, as you know, remains is acute abdominal pain crisis. which may be due to any other intra-abdominal process like cholecystitis and appendix. So this is, I'll tell you shortly about this nitric oxide inhalation in treating vaso-occlusive crisis. And this we started in the year 2015, and it started as like a project. Now we have more than 100 cases treated by this. And in majority of cases, let me tell you that they really benefit from this therapy. So, a nitric oxide inhibits the polymer formation of fetal hemoglobin and disrupts even for preformed polymers. And restores blood flow in periphery, and also regional lung perfusion is likely to be optimized by selective vasodilation of the ventilated lung during breathing, thus improving the ventilation perfusion matching. Collectively, these may have relevance to the mechanism by which inhaled NO reduces pain and pain score as in the vaso-occlusive crisis of sickle cell disease. With this idea, we started, and this cartoon shows the nitric oxide synthesis, whatever the NNOS and ENOS, which are essential for the formation of the nitric oxide in the endothelial cells. So the patient, what we included, our inclusion criteria are mostly adult at above the age of 10 we have taken, and the severe pain, these patients we try to do the scoring system, and which includes SS, S beta thalassemia, and other hemoglobinopathies like ST and ST. And we take a written consent also from them, because it started with the that is the project mode, and the exclusion criteria act if they have taken the splenic sequestration if you suspect, or if they have taken the extended transfusion, we don't include those cases. So this nitric oxide therapy which is given, it's delivered about for 6 hours at 80 ppm through a face mask, then reduced to 40 ppm for another 4. Total period we give about 6 to 8 hours. After a total of 8 hours of treatment, through the face mask using continuous flow delivery system, that is the SLE3600 Inducers, nitrogen dioxide level was monitored all the time in the above system and maintained below 1 ppm. So this is how we give with the face mask. This is the nitric oxide which is given in this. The pain relief we assess by this scale, that is from 0 to 10. This is visual analog scale, and also ability to walk, because when they come they are very difficult, they cannot walk. So I'll show you some of this is patient wise. It is that mostly within 2 hours this nitric oxide inhalation, mostly pain goes and pain score, because the patient also gives the pain score, and the nurse or the attendant is mostly the technician is present, they will mark the pain score. And this is how, sorry, as you can see in this, this is done in the 25, about 20 cases. You can see that pain score from 7 has been reduced by 3 hours to about 3. So this is our story of the nitric oxide inhalation therapy in sickle cell crisis. And fluid is administered to make them euvolemic. We don't give the large volume because there will be problem in that, in the plasma oncotic pressure and increase hydrostatic pressure also. So this is, you have to make them euvolemic. During hyponatremia, the affinity of hemoglobin S for oxygen is increased. Therefore, correction of electrolyte balance is essential, because many times they come with hyponatremia. Patients with sickle cell disease have isocynuria, which leads to difficulty in excreting the sodium load. So oxygen therapy is debatable, but whenever there is a hypoxia, you can give the oxygen therapy. Otherwise, oxygen therapy is not much essential when they don't have hypoxia. Pulse oximetry may not be a reliable method, so you have to go for ABG. The reason being that difference in the oxygen dissociation curve between normal hemoglobin and hemoglobin S is there. Hemoglobin S has decreased oxygen affinity and increased unsaturated hemoglobin in arterial blood. So all low PO2 volume should be compared with ABG determination. So this is how this works, that I go for the acute chest syndrome, that is the pain crisis. After this, we have treated with some of the cases of acute chest syndrome also with nitric acid inhalation therapy. And this is the mode how it works in chest syndrome. Depletion of, in pulmonary vessels, pulmonary vasoconstriction and chest pain is there. Pulmonary hypertension, it leads to pulmonary hypertension and ventilation perfusion mismatch. Then there will be respiratory failure and infarct. So sickle cell anemia, this is inhalation therapy in two cases. One of our students, he published it, that it also helps in the acute chest syndrome. And my humble request to Dr. Vinita is there, that in some of the centers, if you can really provide this nitric oxide inhalation therapy, and it will be a multicentric project to see that how it works in India. So with this, I now close my presentation, and I would like to thank, and there is, I don't think we can take any questions now. Thank you.
Thank you, madam, for such a nice presentation. And now and you give a wonderful talk on novel therapies of nitric oxide inhalation for management of vaso-occlusive crisis and ACS. And I hope this therapy will be.
It's not very expensive also.
Yeah. And I hope that this therapy may be implemented in various sickle cell disease treating centers, so that all the patients will be benefited and for this treated well for acute chest syndrome and vaso-occlusive crisis. Thank you so much, ma'am. And now I invite Dr. Dipti Jain, ma'am. For his presentation. And Dr. Dipti Jain has been 35 years of experience in teaching and treating the sickle cell disease. She has 51 papers in international journals. And I request Dr. Dipti Jain, ma'am, to present his talk. Present her. Dipti Jain, ma'am.
Good evening. Hello.
Yes, ma'am.
Yeah, I'm audible. Yeah, thank you. I think you put me in a very difficult situation, talking after my guru. So it's such a difficult thing. About sickle cell, I have started my work is the first work was with the Mohanty madam, and she's the one who has got me into sickle cell disease. Anyway, I'll be talking on management of morbidity in sickle cell disease. And it will be, I've excluded pain, VOC, and acute chest syndrome. As we all know that sickle cell disease is a very has perplexed aspect, and it has many manifestations, very heterogeneous. Means we can see here a picture of twin brothers, both are homozygous SS. The one is admitted almost every 2 months for some morbidity, and the other is never admitted. You can see the change in the growth also. The triad which we see in India, for which have the maximum morbidities, anemia, infection, and pain. I think you'll all agree that this is the triad of sickle cell disease in our country. Pulmonary hypertension and priapism are less common, maybe in other parts of country, maybe they are seen. One thing which is different, which I want to mention here, is in the literature, it is mentioned that morbidity, what they call crisis, are in extremes of temperature in summer and in winter. However, repeatedly I have observed over years that in our part, the maximum morbidity and mortality is between June to October, I would say June to November. The other peculiarity which our sickle cell have is persistence of splenomegaly even in third decade. About 60% of our patients will have this. With this, I would like to share that we know that the morbidity, the complications are acute and chronic. The common complications which we see in our part, last year as I said, VOC, anemia, and infection were common. However, sequestration, both splenic and we do see hepatic crisis, not as common as splenic sequestration, but we do see hepatic sequestration also. We have also seen pulmonary sequestration. Acute chest syndrome and neurological events also are not uncommon in our part. The chronic complications are, of course, AVN, chronic osteomyelitis. Hypertension is seen quite common in older people, older adults. Hepatopathy, cardiomyopathy, leg ulcers, though uncommon, we have 2 patients. Priapism 1, hypersplenism is common, and splenic abscess is also quite common in our part. Now, this is data from other parts of the country, which also has similar morbidity. I'll be dealing very specifically with, the messages I want to give, because maybe they are not followed. Like if we see anemia, the treatment is blood transfusion, which is no more the truth. Even I have been giving transfusion for anemia in the past. However, let me tell you now, I hardly have a patient whose hemoglobin is more than 8 or 9 grams. And as our observation is, as the hemoglobin goes above 10, the chances of again painful events, stroke are more. So what the message I want to give here is, we need in our country to look for the cause and treat. Nutrition, infection, environmental factors, we have to think about them. And very simple way is just do a CBC with reticulocyte count. I think the important investigation for me in sickle cell more than hemoglobin today is reticulocyte count. And as you can see in the table, we can diagnose, we do have iron deficiency anemia, not in all, 30% of my patients have, and we give for 3 months and then stop. We have combined deficiency, we have blood loss, acute splenic sequestration. So what I want to tell you is that we look for other causes, treat that, and look at the clinical condition of the patient, not the hemoglobin, my concern is mainly about blood transfusion, because inappropriate use of blood transfusion is very, very common, even in my part today, in spite of me continuously talking about it, that it's inappropriate. I think ASH has also come out with the guidelines and saying that hemoglobin is no more the sole criteria to give blood transfusion, which we have been going. Blood transfusion part hai, hemoglobin part hai, 4 hai, let's give blood. Even I have given. Pain hai, give blood. No. What we need for this is the steady state parameters. Means what I tell my patients is, you come to me when you are in pain or you have problem. I want to see you when the steady state. My decision about treatment, depends on the steady state parameters. So it is very important for me to know the steady state parameters. For example, hemoglobin. Okay, if it was 6 and suddenly it has become 3, 4, I'm worried over a period of 7 days. So steady state parameters are important. Here I would like to tell one thing, that hemoglobin S maintains tissue oxygenation even at a lower hemoglobin. Now, these are some indications for blood transfusions where we have to give blood transfusion. Don't say, Dr. Jain says, don't give transfusion. Of course, we have to weigh the risk and the benefit. And these are conditions where we have to give transfusion. The transfusion can be simple or exchange. We very often do exchange transfusion, especially for prevention of stroke, because we can do TCD, and even for management of stroke, acute chest syndrome, we have been doing exchange. However, for sequestration crisis and severe anemia, which is symptomatic, we do give simple transfusions, but never increase the hemoglobin to more than 10. And hematocrit also plays an important role. Now, this slide is more important than the previous slide. These are recommendations by ASH against transfusion. Means we don't have to give transfusion in an anemia who is asymptomatic. Pain crisis, which is uncomplicated, means not associated with other morbidity. And we do not need to give transfusion so often. The other thing I would like to mention here, another morbidity is splenic sequestration, because this is a very common cause of death in patients of sickle cell disease, which is preventable. It is just by educating the parents or the caretaker to palpate spleen. And they are so sharp, they come to me saying, Madam, spleen wadla hai, means the spleen has increased in size. And the triad of splenic sequestration sequence-wise is increase in the size of spleen, because the spleen pulls the blood, fall in hemoglobin, and third is the shock. So they catch the child when the spleen has increased, and you need to not do anything, take the patient to the doctor and put an IV line. You have to maintain the fluid level, but not in excess, because this blood is going to come back after some time. So hydration, IV fluid, and transfusion, not very high, 3 ml per kg of PEC RBCs. If this episode, in our part, I have seen, once they have splenic sequestration, they have recurrent. So if this occurs more than 2 times, the treatment is splenectomy. And in our part, we see hypersplenism quite common. And for that also, we do splenectomy. However, in splenic sequestration, early recognition is the key. Infection, yes. Fever in a patient of sickle cell disease is an emergency, because the severity of infection, and they go into shock, septic shock so quickly, we have no time. So I'm very liberal with the antibiotics when a child of sickle cell has fever. Here I would like to bring to your notice the organisms which were grown in our part repeatedly when we do blood culture. Staphylococcus is the commonest organ, because our treatment will depend on that, which antibiotic to use. Other gram-positive, Salmonella, Klebsiella, E. coli. I think this is what I want to say, that we must think of these organisms when we are treating. Maybe in your part of the country, the organisms are different, but we need to know what they are and give antibiotic. HIV, see, in spite of all the precautions they take. Malaria, yes. I think I see as much malaria in sickle patients as much in normal patients. So you have to think about it. Stroke. Stroke I'm mentioning because 10 to 12% of our patients have stroke, and it is the most morbid, I would say, presentation of sickle cell disease, because they have recurrent stroke. Once they come, they improve, they go, and they come. So I think what is very important is primary prevention of stroke, which all these years I used to think it needs lots of infrastructure equipment. I didn't know we had a USG machine which had a probe by which we could do a transcranial Doppler, which is a screening method by which we can predict the risk of stroke. So we do a TCD from 2 years to 18 years and put the child on chronic transfusion therapy once they are at risk of stroke. Now this is Flanella, who came from UK all the way on her own and showed us that with the probe we had, we could do TCD. And now it's a routine to do TCD in our hospital. And I am sure we are preventing many strokes. A word about hydroxyurea therapy, though I'm not supposed to talk, because we have very different data on hydroxyurea, and we know that there is recommendation by NHBLB to start from 9 months. They don't say start, give an option to the parents to start at 9 months. But then looking at our circumstances, and we see different doses from different parts of the country, and I think after using hydroxyurea for so many days, it should be specific for a specific child, tailor-made. We start with 10 milligram per kg, and most of our children, I would say 70% of my children would improve within 4 months, 25% improvement. If they do not, then is the case when I keep on escalating the dose. Because I think the conditions in our country are very different. We have very high hemoglobin F level. And one of the ways by which hydroxyurea acts is by increasing. I think this may sound controversial to you, but then in long term, we have to think about hydroxyurea. I think this is what I already said. I'm crossing my time. We know that we have increased, sickle cell patients have a longer life. But what we want is a long, strong, happy, and worthy life. Thank you.
Thank you, Dr. Jain, for a wonderful talk. Dr. Jain has told about the various methods for the treating of the sickle cell disease patient, from blood transfusion therapy to hydroxyurea, and what other parameters need to be done for the preventing and stroke in sickle cell disease patients. Well, thank you, ma'am. Now I invite Dr. Tulika Sethman. She is a professor and head in Department of Hematology and All India Institute of Medical Sciences, New Delhi. She has published more than 140 research articles in the field of hematology, and currently funded by many organizations, funding agency for doing research on hematological diseases. Over to you, ma'am.
Thank you. Can I share my screen, please?
Yes, yes, please.
So thank you very much. It is such an honor to be speaking after such stalwarts like Professor Deepika Mohanty ma'am and Dr. Deepti Jain ma'am. You've actually really made my day. Thank you, the organizers, for this. And the next speaker is even more exciting. So without further ado, I will get on with my task of talking about recent medical advances in sickle cell disease. And I'm actually not going to talk too much about hydroxyurea because I thought that would have been covered, but I will talk about some of the newer agents. So sickle cell disease in India is very variable, just as we know that we have tribal areas, we have urban areas, and sickle cell is present in all of them. And the phenotype also varies in different parts of the country and sometimes even within families. The reasons may be multiple, different co-inheritance of other genetic modifiers, etc. which is one of the reasons why one size fits all treatment may not work for all sickle cell patients. So sickle cell disease, as has been beautifully explained by the previous speakers, we have a variant hemoglobin that leads to veno-occlusive crisis, but it is also a chronic hemolytic anemia, and the free hemoglobin platelet activation, cytokine stimulation leads to a pro-inflammatory state, which is why we need to treat it in a very broad kind of a way. So this is a very complex looking chart, but it basically tells you that the pathophysiology is not just hemoglobin S polymerization and vasoocclusion, but there's endothelial dysfunction and sterile inflammation that is ongoing. And this leads to a lot of the end organ damage that we see. And the majority of care that we have, even though these are all evidence-based care, of giving hydroxyurea, giving prophylactic antibiotics and immunizations, etc. But these are actually only symptomatic and palliative. And as we're going to be talking, we've got some newer things coming up, and then the subsequent speaker will be talking even more about some of the newer innovations. So these are what we have been using at present. And yes, many children and many adults do respond, but only the hydroxyurea immunization and monitoring and management is only palliation. So now we're arriving at targeted therapy, which is actually looking at the inflammation and the vasculopathy. And there are many drugs that are being studied, and some of the drugs that are approved at the moment are crizanlizumab and the L-Glutamine, as well as voxelotor. So I'm going to talk a little bit about these in detail, since these are FDA approved and several of these are available in India. So L-Glutamine is actually a food supplement which was approved after its publication in NEJM. And the study actually showed that there was a modest reduction in the pain crisis and some reduction in the hospitalization of patients who were on this product. And even though it has been, it's the first new agent that we had for a long time, somehow it hasn't really picked up, partly because there's a lot of adverse events like nausea, chest pain, fatigue. And many of the patients, even on the study for which it was approved, didn't complete didn't stay on the drug for a long time. And so the other thing is that it's difficult to get. It's not often commercially available. So I move on to the next agent, crizanlizumab, and this is a P-Selectin inhibitor. And this was approved by the SUSTAIN clinical trial. And what are P-selectins? Well, P-selectins are expressed on the platelets and endothelial cells. And whenever there's inflammation, there is upregulation of these. And this is highly upregulated in the sickle cell patients. And the drug inhibits this, and it basically blocks the P-selectin function, improves blood flow, and prevents VOC. And this is effective even in the long term. So how do we use it? It's an injection that can be given once in 2 weeks initially, and then once a month. And the adverse events are actually not very severe, though some 10% patients can get some nausea, arthralgia. And if we look at the study, we can see that when the study was done, there were several dosing regimens that were taken, and the patients on the higher dose actually did the best. And these were patients who had either already been on hydroxyurea or were not on hydroxyurea, and that really didn't make a difference. Both of these groups of patients had an improvement in the VOC rate. So there was a significant decrease in the annual rate of VOC, and a decrease and a trend to decrease to coming to the hospital. And this was quite significant, and much more in the 5 milligram dose arm. And another very interesting thing was there were more than double of the patients didn't have any VOCs at all. So they were VOC free, which is from the patient point of view, very, very good. And the second endpoint that they had looked at was date of hospitalization, and that was also reduced. That again helped patients not have to miss days of work. Now, another interesting thing is that, okay, so VOCs are important, but even if you have patients who have less VOCs or don't have VOCs, or you're able to control the VOCs, organ damage continues. And that is because of inflammation. And another thing that has been noted is that patients with the lower hemoglobin tended to have more problems. And if you could increase the hemoglobin, they would do better. And that's where this newer agent voxelotor comes in. And the principle behind this is that it is a new agent which increases the affinity of hemoglobin for oxygen, and it also helps the hemoglobin stay in an oxygenated state. And though the thought was that it would be very important for VOC, another very important thing that it did was that it increased the hemoglobin. And when this was studied, again, they had several doses, a higher dose and a lower dose that they looked at. And this agent actually reduces the hemolysis, and that is how it increases the hemoglobin. So they followed patients who were on this agent for 24 weeks and then finally at 72 weeks. And then they found that the patients who were on the drug, more than 60%, about 60% of them had an increase of hemoglobin, and this was more in the patients who had the higher dose. The other thing that this is the hemoglobin increase that is there, and it is a sustained hemoglobin increase. So the anemia is continuously improved. And the other things that they looked at, the markers of hemolysis were reduced in the patients who were on the drug. And it did, in fact, also reduce the VOCs, and this correlated with the increase in hemoglobin in these patients. And these were other events that were reduced in patients who were on the drug. Another interesting finding was that the TCD velocity seemed to improve when patients were on the agent, and this also correlated with the hemoglobin improvement. And patients who had abnormal TCD velocities on the drug had a normalization after 24 weeks of therapy. So this agent seems very interesting and very promising, and it has been studied in pediatric patients, and the results are pretty much similar in the pediatric patients as well. And this is an oral therapy, and it's a once-a-day dose, and it does seem to have some disease-modifying effects. And unfortunately, it's not available in India as yet, but it seems to have many beneficial things. So there are a lot of other drugs that are in trial at the moment. There are anti-inflammatory agents. Some of them are on study, but then there are some off-label things that have been used, like simvastatin and even omega-3 fatty acids. And though there are not many studies, but some of the studies do show that they may have some role, but not very significant. Antiplatelet agents were studied, and though Pansugrel didn't have much of an effect, but the study, or the HESTIA-3 study, is ongoing, and we're looking to see if this antiplatelet agent could actually be beneficial in sickle cell or not. There are some studies looking at anti-neutrophil and endothelial agents, though these are more in animals, and people have even tried IVIG. So that may be another interesting agent that can be useful in patients, particularly in the COVID times. There are other potential targets where they're looking at, including complement pathway targets, because if we can control the inflammation, we can control the end organ damage. Another interesting group of agents are the fetal hemoglobin inducers. So these can be more effective than the increment that we see of hemoglobin F by hydroxyurea. And another target is the BCL11A, and that is actually also being looked at not only by drugs, but also by gene editing. So the only curative things that we have at the moment are still allogeneic bone marrow transplant. There are some innovations that are being done looking at RIC and haplotransplant, but in India, we have very few patients who actually go for transplants. And the next speaker will be talking about the gene therapy and the gene editing. Monitoring is really important, and at AIMS we have developed a rapid MR sequence for doing T2 star MRI, where in place of the usual 30 to 60 minutes, we have a rapid sequence that takes 8 minutes, and this can be done with any MRI machine, and we have a non-commercial algorithm that we are happy to share with, because this will reduce the time and improve monitoring for patients who are on a regular iron transfusion and need monitoring, and this has recently been published. So to summarize, we do have a lot of evidence-based strategies that we are using for our patients, but as I said, there's a variability in phenotype, and there are some patients with the more severe phenotype who may benefit from some of the new FDA approved agents, and there are many more innovations that are upcoming. So even though these patients do have a difficult life, hopefully there are some new things that we can do to improve the quality of life. Thank you very much for your kind attention.
Thank you so much, ma'am, for such a lucid presentation. Ma'am has talked about the various new drugs agent which are coming up and which are in market now for treating the vaso-occlusive crisis, as well as the reducing the morbidities for the sickle cell disease. Thank you so much, ma'am, for a nice presentation. Now I invite Dr. Alok Srivastava, sir. Although he doesn't know any introduction, and he is a pioneer worker for introducing gene therapy in sickle cell disease in India, and he is working very hard, and he is director of the Center for the Stem Cell Research, Christian Medical College, Vellore. Over to you, sir.
Thank you. I hope you can hear me and see my slides.
Yes.
Yes.
Okay. Thank you very much for the invitation to be part of this program. It's been very interesting and educational so far. I was asked to talk about gene therapy for sickle cell disease. When I looked at the program, I realized that maybe there hasn't been much discussion on stem cell transplantation, which is the only currently available therapy that will cure sickle cell disease. And so I thought I'll talk very briefly about that and just mention some of what's happening. In 10 minutes, you can only get a very high level overview. Since both the talks on epidemiology were skipped for various reasons, it may be just good to mention, though it's possible that many in the audience would be familiar with these numbers, that this commonest monogenic disorder of mankind leads to a lot of children being born every year with these major hemoglobin disorders. In India, we don't have accurate estimates, but the usual numbers floated for thalassemia is about 8 to 10,000. It's certainly much more for sickle cell disease, given the kind of population that's affected. A lot of people in the tribal areas. These estimates are much more difficult. It could be anywhere from 15 to 50,000. I'm not sure that we have good estimates. The bottom line is that there are a lot of children being born in the absence of effective control programs. So the only cure available so far is the hematopoietic stem cell transplantation, starting with thalassemia major almost 40 years ago. But even in those 40 years in the world, for thalassemia itself, less than 10,000 transplants have been reported. So imagine, 50,000 children being added every year, but less than 10,000 transplants being reported in 40 years. Even if half or more of those transplants are not reported, and maybe the real numbers in the world could be 15 or 20,000, you can see the supply-demand discrepancy. This number is even more terrible for sickle cell disease, where it's estimated that maybe 250,000 children are born every year around the world, and the number of stem cell transplants for sickle cell disease is indeed very small. Now, in India, for almost 30 years, starting in 1991 from CMC Vellore, we're doing thalassemia major transplants. Till now, maybe somewhere between 2,500 to 3,000 transplants. Not an insignificant number compared to the total in the world, but completely insignificant in terms of the number of people, children and their families who need this help. For sickle cell disease, the story is even worse. In India, we have done close to about 300 transplants. The tragedy is that it is done mostly for people from overseas who come here for their treatment. Very few of these transplants have been done for sickle cell disease. So obviously it requires a lot of thought. As has been mentioned already by several speakers earlier, even though the hemoglobin F levels in sickle cell disease are relatively higher compared to those in Africa, there is huge amount of morbidity and mortality. There's a whole spectrum of disease that exists in our country, and it is not correct to say that these children do not require more intensive treatment, including transplant. So without deliberating further, I thought I'll just show you some recent data that came out regarding matched sibling donor transplant. You know, there are support systems available for matched sibling donor transplants for thalassemia so far in the country, but to my knowledge, there isn't any such support system for children with sickle cell disease. They can have excellent results if they are transplanted early, and as you can see here, the success rates are in the 90 to close to 100% range for some of them. So therefore, there's no reason why a child with a significantly severe phenotype, and there are ways to identify that, with a sibling donor should not undergo transplant. But my task today is not to talk to you about transplant. My task is to talk to you about gene therapy. And so I thought I'll just put up this simple cartoon to explain what gene therapy means. So for whatever reason, if a gene is not functioning properly in a person, then you can do several things. In the past, it was mostly gene addition as shown here, but as I will show you later, now we can gene modify. So gene addition means that you synthesize a transgene, that is a normal gene, and then you somehow get it into a specific cell in the body of the patient that will allow expression of that gene. To get that gene into the specific cell in the body of the patient, you require some kind of a vehicle, and that's called the vector. And usually the vehicle is a virus that is non-infectious, but it could be non-viral particles as well, including liposomes. So here we have a vector which could be various types of viruses. In hemoglobin disorders, the most common one being used is the lentivirus. And this then is infused, or it may be infused into the patient, or it may be actually treated ex vivo. In the case of hemoglobin disorders, it is ex vivo. Once this reaches the cell, then it enters the nucleus. It may integrate with the genome and lodge itself either in specific sites or undergo random integration. The bottom line is that you will get expression of protein, and that's the protein that you're interested in, and in this case, hemoglobin, the globin part of hemoglobin. So this is how it's done, the gene therapy in this case here. So you mobilize stem cells. This is fairly standard in the world. People will give GCSF with or without plerixafor. This will mobilize stem cells from the bone marrow. Then you collect these stem cells and you process them in the laboratory. Once it's processed and you have modified and introduced the gene, now you have the modified CD34 cells which now carry the normal gene in this case. Now what you need to do is to myeloablate. You need to abolish the existing hematopoietic system by giving conditioning therapy with chemotherapy, and then infuse these cells back. Once you infuse the cells back, it takes about 2 to 4 weeks for them to engraft, and then they start producing the protein from this transgene that was introduced into them. So that's the way it works. So with this approach, we have success now with thalassemia, and so far not yet with beta-0 thalassemia. And so this was the results of a study sponsored by Bluebird Bio that was published in the New England Journal in 2018, showing that people with beta plus thalassemia, the ones with the beta-0 did not do so well. But as you can see here on the right hand top, the non-beta-0, a good number of these patients have become transfusion independent, and therefore this data was enough to approve this drug called Zynteglo, which is now available as a gene therapy for beta thalassemia transfusion dependent non-beta-0. The only problem is that it costs about $2 million. I thought nobody in India would ever get a treatment that costs $2 million. I was wrong. In the last week, at least 3 children have been treated for spinal muscular atrophy with AAV, adeno-associated vector-based therapy for for 15 to 16 crores per dose. So that's about $2 million. So certainly it looks like, okay, very few, very select few. And one of those was by crowdfunding from 65,000 people. I mean, these are exceptions. These cannot be the rules. So we need alternatives. Now, before we talk about alternatives, I just wanted to mention that there have been some challenges with gene therapy, lentiviral based, in sickle cell disease particularly. So the thalassemia story is going on for at least 10 years now, and so far there hasn't been any leukemogenic transformation in several gene therapy patients with thalassemia. But in sickle cell disease, there have been two recent cases, one reported last year, one earlier this year, and in fact this led to the trials being put on hold. Now, a lot of analysis has been done of this data, and the overall conclusion is that it is unlikely that the transformation into myelodysplasia or AML is related to the lentivirus that's being given. But the jury is still out on that, and we need to be careful anytime we use a vector like this. So therefore, what are the other opportunities? The other opportunity is to actually do gene editing. Time doesn't allow me to get into details of this, but in some ways, this is molecular cut and paste. So there is a single mutation, as you know. If you can find a way to correct that mutation in the patient's own gene, then that's amazing, isn't it? So therefore, you modify this in a way that it gives you correction. The other way is that if we were continuing to produce hemoglobin F the way we do at birth, then it would be, sickle cell disease would not really be a problem. The reason we don't produce hemoglobin F is that by 6 to 9 months, BCL11A gene, the distranscription factors, shuts down the gamma globin production, and therefore hemoglobin F goes down. So if we can find a way where you can again enhance the function of BCL11A gene, again shut down the function of BCL11A gene and reduce the suppression of the gamma globin, then you can increase HbF production. And this is what's been done. Several patients have been treated, and this is without lentivirus. So this is another good approach in clinical trial. A similar work is being done at the Center for Stem Cell Research by both Dr. Mohan Kumar and Dr. Sarona Bhavan. They are in fairly advanced stage of preclinical work doing the mouse studies, after which it's a question of producing the therapeutic product and proposing a clinical trial. The other approach to shutting down BCL11A, other than through CRISPR-Cas9, is to actually use an shRNA. And this approach has been promoted from the Boston Children's Hospital, and this trial has already recruited about 6 patients. And as you can see, that there is initial early good response. So another way, by using shRNA to shut down BCL11A, so that you then get more production of hemoglobin F. So these are two other approaches being used for gene therapy for hemoglobin disorders, including thalassemia and sickle cell disease. And this work, actually, we have produced our own shRNA-based vector, and Dr. R.V. Shaji has been doing this work. Again, this is fairly advanced, being tested in mouse models. And if that goes well, then we are looking at moving those to the clinic as well. So in summary, you have a patient with a blood disease that's based out of hematopoietic stem cell being defective with the beta globin gene. And so you can collect stem cells from them, and you have two approaches. One is to use a lentiviral based gene addition on the right, which is shown in red. It can be a beta globin gene or a gamma globin gene that's added, or you have a lentiviral based BCL11A shRNA based suppression. And then on the left, what is shown is gene editing. There are different ways to do gene editing. Zinc finger, we are using CRISPR-Cas9, and with that modification, you then get the corrected hematopoietic stem cells, which are then put back into the patient as an autologous transplant. So with that, I'd like to stop. A major challenge in these therapies have been that not everybody is getting the same response. Some people are increasing their hemoglobin by 2-3 grams. Others are increasing their hemoglobin by 6 to 8 grams. So that the final hemoglobin in somebody who was usually less than 5 grams, in severe thalassemia major, and in sickle cell disease, of course, it will be higher. What do you consider adequate gene therapy? Well, that's a matter for debate. In the absence of time, I'll not debate that, but important to know as long as it changes the phenotype to a situation where patients can be asymptomatic, not requiring transfusion, and able to lead a normal life, I think that could be a functional definition for cure. So with that, I'd like to stop and remind you that gene therapy is advancing rapidly for both thalassemia and sickle cell disease. One product is in the market, but not very affordable. And therefore, we need local options, both for the science as well as the technology for producing the vector. Once it's established, it could really transform the way these diseases are managed, even in our country. With that, I want to thank you for your attention, and we'll look for questions in the chat box. Thank you.
Thank you so much for such a kind presentation. And Sir has told about the gene therapy and bone marrow transplantation options in sickle cell disease and thalassemia as well. In a very short time, he has given the understanding of how the gene therapy works and what are the challenges currently for implementing gene therapy for sickle cell disease. Thank you so much for such a kind presentation. Now I invite Dr. Raj Subraman, sir. He is a scientist in ICMR-NITH at Jabalpur itself. He is working very hard for diagnosing sickle cell disease in tribal areas and for screening and family. He will talk on sickle cell disease in tribal current challenges and issues. Over to you, sir.
Good evening to all, and thank you to the director for allowing me to present our work. And I congratulate my colleague Dr. Ravindra Kumar for putting up such a wonderful seminar today on the Sickle Cell Day. And unlike my previous speakers, I'm not going to speak on clinical aspects or the newer therapies that are available. And I'm going to speak on the challenges that we are facing currently in India on the screening and evaluation of the numbers. And so this is the typical distribution of HbS status in India. And on the right, the communities with high prevalence in different regions of India is given. And the prevalence varies from anywhere from 1 to 40%. That's what is documented in several articles published from India. And despite the number of prevalence in many papers published, the actual burden in India is still elusive and not accounted for. And once to identify the burden is the main issue, because the government has to prepare for the treatment and these management strategies. And unless we have the numbers, it's very difficult to proceed further. So as I mentioned, 1 to 40% is the average prevalence. And the tribal population in India is about 8.6% of the total population of India. And the states, Madhya Pradesh, Odisha, Maharashtra, Rajasthan, Chhattisgarh, Gujarat, Jharkhand, West Bengal, and Karnataka carry the maximum tribal populations. And they nearly account for more than 80% of the total population. And there has been efforts to screen tribal populations in many states. And Gujarat has been most successful so far, has screened more than 10 million population. And followed by Maharashtra and Chhattisgarh. Dr. would have been very happy to listen to Dr. Patra's experience, who spearheaded the screening in Chhattisgarh, and nearly 1.5 million people had been screened there in the Sickle Cell Institute that he initiated. And Maharashtra also has been a successful story. States, Rajasthan and Odisha also are carrying out screening. And the earlier, there has been a program in Odisha where on sickle cell control program, where a lot of screening had been done. But unfortunately, the numbers across many states are not available on a general database. And Madhya Pradesh accounts for the maximum number of tribals in India and accounts for about 22% of the total tribal population in India. And there was a a major project envisaged and initiated by Madhya Pradesh government in collaboration with our institute. And we expected to screen about 50 lakh population through the medical department in Madhya Pradesh. The progress has been little slow, and the facilities across 51 states have been created, but due to last 2-year COVID pandemic, the screening has been delayed. And we have patients across the states where tribals are present, and general awareness about the sickle cell anemia amongst the caregivers and the general population is absolutely very low. And because the doctors are not aware about the communities or the prevalence in those states, they generally treat any patient coming to the clinic as iron deficiency anemia without knowing that there is an underlying cause. And most of these tribal populations are coming from inaccessible areas, and their nearest help is from public health systems and primary health systems, where there is no diagnostic facility. And they cannot go to private players because of the expense, and there are a few NGOs available. And all these systems are working to identify the tribal populations affected by sickle, but because there is no crosstalk and there is no data available on a general pool, it's difficult to identify the populations that are affected, and there is no systemic numbers on them. The public health system has poor performance in the general view of the public, and there is a lack of facility and low satisfaction. And the accessibility is one of the main things in the tribal areas where distance and transport is not available. So, and the general awareness about the what are the shortfalls or the gaps. Low awareness among communities and caregivers, no national data, variable models of screening, and no referral systems within these systems of NGOs or private partners. So the tribals are stuck to the public health systems. And how do we bridge the gap? We need to establish uniformity of screening and comprehensive care in all states. Inclusion of non-tribal population in screening, because generally it is assumed that the sickle is a disease only prevalent among tribes. Now, there are many reports. The prevalence is higher among the sickle on scheduled castes and other backward communities. So all need antenatal mothers to be screened and followed up, and to enable faster screening, point of care screening methods have to be adopted, and digital support has to be included there. And we also need to scope into the raw data of testing at central point on a priority, and establishing a network for public-private partnerships and NGOs to cater to the affected populations. So once we establish or bridge the gap, we cannot stop there. We need to have sickle cell registries. ICMR and AIMS have been making efforts to start the registries. Unfortunately, due to the COVID pandemic, the progress of these registries has been hampered, and we need qualitative studies among Indian populations also. And because when we go for large-scale screening, many of the activists believe it could cause stigmatization. So we need to have a IEC done, and we have to create a lot of awareness, and we have to look at the quality of life and morbidity patterns. Documentation of morbidity profile on crisis and management, because in India, the Indian haplotype is considered milder to the African haplotype. So we need to have our own management criteria, and unless we can document more clinical studies, it's difficult to have our own control strategies. and genetic counseling and establishment of special centers for treatments are needed across the country in all the possible districts where there is more prevalent of sickle. And involvement of NGOs for better community reach. Medical education research in sickle cell anemia is necessary in many centers, and periodic comprehensive health camps for SED patients. Empowering local health workers with mobile sets and access to transportation for faster outreach is essential in tribal areas. Health literacy, school health programs for the teachers in schools to take care of the children who come with sickle in the school is essential. And finally, we also need to have a digital education and engagement program. And I would take this opportunity to inform that we are trying to create a digital health education and engagement program, and we are hopeful that will be launched in the next couple of months. And this is the overview of the entire procedure that we need to look at. We need to have self-help groups and resource mobilization for the patient support. We need to have a sustainable system. We need to identify the disease burden, unified single national program for SED, addressing stigma, collaboration of public-private partners, a network of referral systems for the entire community empowerment. And as the final take-home message is integration of all stakeholders and partners, common goal, improvement of health access to deprived populations, promote equity in health conditions, access, coverage and services, improve quality of care, increase the efficiency of health delivery, allocation and management of resources, ensure sustainability, promote social participation in planning, management and delivery of health services. And thank you, and let's all unite to fight this sickle. Thank you.
Thank you, Dr. Raj Subraman, sir, for such a nice presentation. And sir told about what are the challenges in the tribal areas to get the proper healthcare services for their management. Now I invite Dr. Mrs. Vinita Shrivastava, ma'am. Ma'am, Vinita Shrivastava, madam, is currently working as an advisor in Ministry of Tribal Affairs, and she also a consultant in National Health Mission Mumbai, Delhi. And over to you, ma'am. We will talk upon the national guidelines and programs to be followed for the betterment of the sickle cell disease patients.
Thank you, Dr. Arvind. It was very nice to hear all these speakers, eminent speakers, and it was a good learning to me when I was hearing Dr. Deepti Jain, Alok, Tulika, and just now Dr. Raj Subraman and everybody. It was a great learning to me. So if we talk about the National Health Mission, as we understand that the guidelines were initiated in 2014 itself, and we started with the program in 2014. So if we see the progress in these states, and as such, the guidelines has really worked a lot and helped in these states to come up with some strategies and for the prevention as well as the management. But somehow, if I feel what Dr. Raj Subraman was telling us, that much of the things has to be needed, still has to be done. So the concern was that how we can make up a different roadmap for, especially for the sickle cell disease, where the prevalence is too high. When we compare thalassemia and sickle cell disease, if we see around 10,000 children are born with thalassemia, and around 25,000 children are born with sickle cell disease. This is estimated. The concern is that the estimations are not correct. As my previous speakers has already talked about the data, which is very important. We don't have a data. Even the ICMR data, which is currently available with us, is not sufficient because it has been done in different locations, but it is not as per the norms. Where we heard about that in Gujarat, 1 crore people were screened, but we don't have the exact data with us to how to go about it. And for getting these strategies and the prevention, it's very important that the data should be there and it should be well analyzed, which is still lacking. Even in MP also, we heard that screening was done, But when we talk about Jabalpur itself, they are taking care of 4 states, like it has been taking care of Himachal Pradesh, they are taking care of MP, Chhattisgarh, and one more state was. So my only concern was when we were looking for the data, we couldn't get the entire data, which is very important. And I am very happy because today in the morning when we had this webinar from the Ministry of Tribal Affairs, where the minister was also there, they have come up with the portal. Actually, there is a SWAS portal which has come up, and there is a sickle cell disease corner where we are trying to get the data from the entire country. And this is our job, I should say. Now, the first thing, we need to have the data at the central level, where from the state districts, the data should be compiled and it should be gathered at one place. And the data security, which is equally important, has to be taken into account. The second thing was like about the awareness. When we were talking about the awareness, yes, awareness is very less. Still, people are going for the marriages between them, and which is a real problem. So avoiding those marriages and counseling those people, why it is important is, again, counseling. If I say we don't have good counselors, so genetic counseling is again a big challenge for all of us. While I'm telling about, because these are my experience in these states, what I have found that still the numbers of the patients are increasing. And why it is increasing when we are doing such much of screening? When the screening is done, everything is done, then why the patient numbers are screening and the disease burden is going high? So this is a very important aspect that we have to understand in a way that we have to do a screening in a manner where we have to collect what is happening. If a person is a disease, we need to know about it, so the management is done in a proper manner. And secondly, if a person is a carrier, then we have to counsel those carriers. Please see that you are a carrier and you have to understand that you don't get married to the same trait. So these things are very important. And when we talk, so education is again a challenge, and we are just trying to get this as a lesson or as a chapter in the CBSE, which is very important. That why people don't understand, and till class 12 they have to understand that this is important, and education with the CBSE or in the adolescent, it is equally important, which we are planning to do it in future plans. And not future, but we have started working. Again, then third thing was about the nutrition and women, which was very important, and child nutrition also. The patients who are sufferers, now they are not getting enough medicines, they are not getting enough nutrition that they come out with. So we understand this is a progressive disease. It's not like that it is done and every year something or other happens to the patient when they grow up. So many issues are there. So the multiple centers which we have developed, like ICHS centers, which we call as Integrated Center for Hemoglobinopathies, where the multi-stakeholders has to come forward to get this management done, which is, we are just trying, but still I see that we don't, our clinicians are not much trained about it. When we were doing the training part, I found that the clinicians are not aware of the things, which is much important. And when I was hearing about the gene therapy, it's such a good thing which is coming in India. But still, we have to learn that these patients who have to get these hydroxyurea and other things and the blood transfusion in time, they are not getting it. And when there is an issue of pain, the pain crisis, how this has to be managed is again a challenge for us. So training programs are much needed. And this, during the Corona period, we have learned that these training can be done easily. So we are trying to do this training programs, as well as the telemedicine part is also being taken up, where we want to put up a kiosk in each and every center across the country, which are the good centers, where we can take up these issues, and the hematologist or other physician trained or pediatrician can tell people how to go about it, or they can help people. So these kiosks are very important, which is really required. Again, a challenge which we are facing. Why I'm changing challenges? Because challenges, when we learn, we want to learn, it is from our challenges only. We have to see our challenges, what exactly. Every time the ministry or any ministry cannot pat their backs that we have done. But again, every day is a learning day for us. So with that, I would like to say that this Sickle portal will be helpful to you. And I think 2 vans, they have just today, the Ministry of Tribal Affairs with the help of Piramal Swas has basically given 2 vans to 2 districts in district Kanker and district Khunti in Jharkhand, where they are going to do the screening in the villages. Let's see how this works out. This can be a model if we come out that these MMUs are able to do the screening at the periphery level, at the village level, then we can initiate these models as well for the periphery level. For the rapid screening, again, we have come to know, and Jabalpur was one of the centers which were doing basically validation of these rapid screening tests, which is again an important task for us, that if we get these things in time, we will be able to screen much of the people, because I'm finding that this solubility test doesn't give a proper reports, and we are getting the false positive reports also. So these things are very important, and then the transportation, and then the going to the districts to get the HPLC or electrophoresis test for the confirmation. This is again a big challenge for us. So while we have initiated so many things from the Government of India, but still we are lacking behind. And with the newer therapies and all, it's really, I mean, we are just waiting for those things to come, because today we were hearing Dr. Anurag Agrawal, who was in the morning, he was there with us in the session. He was, who is the director of IGIB. He was telling about the CRISPR therapies and other things also, and how the screening for this also can be done in a paper where you have to see the bands and all. So learning is good, but we need to initiate these things in the peripheries, which are very important to us. Government of India has taken a step to help these patients for prevention as well as the management. But state governments has to, because as always we say that health is the state subject, and health departments and the Ministry of Tribal Affairs, NGOs, ICMR institutions, everybody has to come forward. As Dr. Subramaniam has rightly said, that everybody has to come forward and get together. So my urge is that we are just trying to develop a roadmap, a simple roadmap, which is going to help at the PSC, CSC district, and then to the medical colleges. We are just trying to develop those roadmaps, which will be helpful for the states and the districts to get along with these guidelines, and they will be able to, I hope that they will be able to manage the show, because at the PSC, CSC level, we really have to teach our doctors, our paramedical staff, that this has to be taken as an initiative. And especially the Anganwadi workers also, they also need to be trained. The Ashas needs to be trained, which is very important where we can, because they are the people who are in the peripheries and running around when these antenatal mothers across. If they also learn, then it will be easier for us to do the antenatal, and the also they will be able to help us in the counseling part also. So with these words, I would stop here, because much of the things has to be done. I am just humbly requesting you that you all have to join hands to, when we are drafting this roadmap, maybe in 2 or 3 days, I will be sending this roadmap across the states and across the experts, I should say. And please help me out in drafting these roadmaps, so it will be helpful for the country and as well as the states. Thank you so much.
Thank you, ma'am. Thank you for providing us an insight of the government's program and agenda for screening and management of sickle cell diseases. Thank you so much. Since we had 2 epidemiological talks pending, Dr. Patra, who had connected with us, but then due to poor connectivity, the call was not successful. We are still waiting, but the connectivity is still poor. This is what he has informed us. Dr. Sargent also is not getting proper connection, but he is agreed that he will be connected through WhatsApp call. So we will be putting his voice in our mic, so that everyone can listen to his words. Dr. Sargent, can we put you on the message?
Okay, sir. Now I will put your voice to the program. Can you please? We are also showing the slides, and we just speak over them. Is that fine? Yes. Okay. So.
Sign up, which says Global Perspective.
Yes, sir. We are ready, and.
Right. Yes. I'm ready when you're.
The slides are also shared.
So give me the next slide, which should be the outline of Africa.
Yeah. It is on air.
Right.
Yeah.
Fine. Okay. Now this is looking at the distribution of the sickle cell trait in the African continent. And basically the messages are there's not much at the north, there's very little in the south, but there's a huge amount. These figures represent the frequency of the sickle cell trait in Sub-Saharan Africa. Now, if we move on to the next slide, you'll see the worldwide distribution, particularly as it was set 30, 40 years ago, where it was believed that most of the gene came from Africa, and because of the slave trade, it moved into South America, North America, and the Caribbean, and then latterly emigration to Europe. And the message there is that the disease seen in the Western world was predominantly among people of African origin. But if you look carefully around the Mediterranean, the eastern province of Saudi Arabia and central India, of course, you will find a lot of the disease. And if we go quickly to these areas, you move on to the next slide. It's an outline of Greece. Can you see that?
Yes, sir.
Right, fine. And if you look at the Halkidiki Peninsula with 3 fingers sticking down to the Aegean Sea, the middle finger, Scythonia, those numbers are the frequency of the sickle cell trait in villages of northern Greece. And you can see it goes up to 32% of Greek patients. So if you move into the next slide, you will see a family from the village of Ormelia in northern Greece. Can you see that?
Yes.
With a mother and father. The mother and father both have the traits, and they have 2 children, but both SS disease. So let's move on now to the next slide. And now we're going to do a comparison of the distribution of some of the blood indices in Jamaican patients and in Greek patients. And you're looking at the graph now, are you?
Yes. Yeah. Yes, we are in the graph.
You can see. Good. All right. Now the red columns are the data in Jamaica. The blue columns are the data in Greece. And you can see that Greek patients with SS disease tend to have higher hemoglobin levels. And if you look at the next slide, which is similar, but this is now looking at the immature red cells. This is an indication, reticulocytes are an indication of bone marrow activity. And here, the Greek patients tend to have lower reticulocyte counts. So they have high hemoglobin, they have lower reticulocyte counts, so there's something protecting them from sickling. And if we look at fetal hemoglobin, which is one of the important genetic determinants of severity, there was absolutely no difference. So clearly there is something about the Greeks that we don't understand, but it does give them more mild sickle cell disease. Now, if we move on to the next slide, it's got the Greek sickle cell disease. Are you seeing that with a summary of the hematology and the clinical?
Yes.
You are excellent. So hematology, they've got higher hemoglobin, lower retic count, so they're destroying their cells less rapidly. They have similar fetal hemoglobin, so that's not the answer. Another possible explanation would be if they had a lot of alpha thalassemia, but they don't. But they do have a lower concentration within the red cells. So somehow they are protected against sickling. And clinically, this means that their spleens, the splenomegaly, tends to persist. They still have bone pains, but leg ulcers, which occur in 30% of our Jamaican patients, were very rare. And priapism, the painful erection of the penis, occurs in 40% of our patients, and that's also rare. So we're seeing in Greek disease difference in hematology, difference in clinical features. If we move on now to Turkey, which is the next slide, you can see on the south coast, about 10% of the population have the sickle cell trait. And the next slide shows a typical family. You're seeing 3 ladies sitting on a sofa, and the gentleman sitting behind. Have you got that slide?
Yes. Yes.
Yeah.
You have, good, all right. So there, the father and the mother both have the trait. The lady on the right has the trait. The lady on the left has SS disease. So we're seeing the disease now in Greece, in Turkey. Let's move on now to the next slide, to northern Palestine. And there, move on to another family. And here you should see three ladies sitting down with lots of children. Are you seeing that?
Yes.
Yes.
Perfect, perfect. So the lady on the right and her husband behind both have the trait, and their two children on either side have SS disease. The lady in the middle is the sister of that lady, and she has the trait, and she has a child with SS disease. And the lady on the left is the sister of the other two ladies, and she has SS disease herself. So in that single extended family, you have actually four people with SS disease. Let's move on now down to the next slide is Saudi Arabia. Can you see that, the outline and map of Saudi Arabia?
Yes, sir.
Perfect. And there you see 25. That's the frequency of the gene in the eastern province. And that is a different form of the disease. It's called the Asian haplotype. And that is shared by you, in the eastern province and patients in India. But if you look at the other side of Saudi Arabia, you see a 5 in the bottom left-hand corner. And there, this is African disease. So there are two forms of sickle cell disease in Saudi Arabia, the African form in the southwest and the milder Indian form in the eastern province. And if we move to the next slide, we're now in Qatif General Hospital. If you see a gentleman standing there with a child in the bed.
No, sir. Yes,
Yeah.
yes, we can see.
You've got it. Good. The gentleman standing up is the father, and he has the traits. His son, in bed with bone problems, has SS disease, and another son who's visiting also has SS disease. So then we're beginning to see that this obviously is not an African problem. We all knew that. But let's move on. Oh, this is in King Faisal Specialist Hospital, where we interviewed patients from the east and the west and realized that they had two different forms of the disease. And there you see me interpreting with Elham, the interpreter lady. And then we're going to ask the question, how does the disease in eastern Saudi Arabia differ from Jamaica? And we'll look at the hemoglobin levels. You've seen this before. The red columns, you can see that. You're looking at the graph now?
Yes.
Yes.
Right, okay. So the red columns are Jamaica, the light blue columns are Saudi Arabia. And the first thing is, obviously, they have much higher total hemoglobin levels. Let's now look at reticulocytes, and the next slide shows the same pattern with reticulocyte counts, and they have much lower reticulocytes. So they have something that is inhibiting sickling in the eastern province. And one of the genetic factors that we know does this is, of course, levels of fetal hemoglobin. And if you look at the next slide, now you'll see the red graph, which is the red columns, which are Jamaica, the light blue, and there's this huge shift towards higher levels of fetal hemoglobin in eastern Saudi patients. So we look at the next slide, and you'll see the summary as we saw before with the big patients. They have higher hemoglobin, lower retics, much higher fetal hemoglobin, and frequent alpha thalassemia. And once again, the spleen is persisting, which is very important because the spleen sits in the belly and it's there as a filter that takes out damaged red cells and bacteria that get into the blood. And one of the problems in sickle cell disease is there are so many damaged red cells. That filtering function is damaged. And so bacteria that get into the blood are not removed as they should be. So that is important. Despite having milder disease, they still have a lot of bone pain, the so-called painful crisis. They still have chest problems, and once again, leg ulcers and priapism. both rare. So we're beginning to see differences in the disease. And then finally to home, to India. Now you're looking at an outline map of India.
Yes. Yes.
All right, fine. You can see that the gene occurs in two areas, really. Across the center of India, where there are large numbers, and these are the frequencies of the sickle cell trait. And then in the Nilgiri Hills in the south, you have a tribal population where the gene was first described in the south. So you've got largely two foci, a huge one across central India and a small localized one in the south of India. And the next picture actually shows Mrs. Sargent. Now, can you see that picture with a lady alongside?
Yes.
All right, fine. So this is actually, that little lady is an SS patient of the Panayan tribe. This is in Kotagiri in the Nilgiri Hills. Mrs. Sargent is put alongside. Now, in Western terms, Mrs. Sargent is very short. She's actually only 5'2". But this gives you an idea of how tiny some of the tribal people, especially with sickle cell disease. And interestingly enough, we went back to Kotagiri some years later, and I showed this picture, and I said, now, who is this? And they looked at her, and they said, oh, that's Narayani. And I said, well, what happened to her? And they said, well, she died recently at the age of 42. And when I queried about whether how they knew her age, they said, well, we know this accurately because she was abandoned as a baby in the hospital, and she was raised by the staff of the hospital. So here we have a person who's severely affected, but did, even in those circumstances, survive to the age of 42 years. So now let's move on to the next slide. And here, can you see this? This is a laboratory set up in a lecture theatre. Can you see that?
Yes. Yes.
All right, fine. And that is the visiting team that came to work with Professor Bimal Kaur, who's one of the grand gentlemen of sickle cell disease at Birla Medical College in Western Odisha. And the people there, well, in fact, most noticeable is Andreas Kolotzik, who's the gentleman sitting in front of the doorway, and he is now a professor of pediatrics in Germany. But together, we actually saw a lot of patients, and we're going to give you some of that information. So we move on to the next slide, and this was one of the families. Can you see that? Yes. A gentleman, and can you see her?
Yes, sir. Yes.
It says, and finally, India. All right, fine. Now, on the right is a doctor, a medical doctor trained at Birla. He didn't know he had the trait, and his PhD wife in economics, she didn't know she had the trait, and the first child they had was a young lady in the center who has SS disease. So even in this rural community where 30% of the population had the trait, they, intelligent, educated people, didn't know of the significance. So now let's ask the questions we've done before, looking at the hemoglobin distribution, and we're now looking at a series of graphs again. Hemoglobin, can you see that? This is hemoglobin levels in Jamaican Indian SS patients.
Yes. Yes.
All right, fine. And once again, the Jamaican columns are red, the Indian columns are orange, and there's a shift in Indian patients towards higher hemoglobins. The next slide shows the reticulocytes exactly the same. They've moved towards lower levels, so you're seeing exactly what you've seen in the eastern province of Saudi Arabia. And then if we go to fetal hemoglobin and look at this shift, this is the third one, HbF in Jamaican and Indian patients. Can you see that?
Yes. Yes.
Perfect. And now you can see the Jamaican distribution, the red columns is to the left, and then this huge shift towards higher levels of fetal hemoglobin in Indian patients. So this is important because this does change the features of the disease in India. Let's look at the summary, the next slide. And can you see that?
Yeah. Yes.
Hematology, hematology, higher hemoglobin, lower retic counts, high levels of fetal hemoglobin, frequent alpha thalassemia. The those two factors, both genetically determined, both inhibit sickling, so the disease should be milder in terms of intravascular sickling. And clinically, they got big spleens, often they still be, even though they should have less sickling, they've still got frequent bone pains, but they rarely have leg ulcers and priapism. So we're beginning to see important differences. And we're almost at the end. I'm sorry, I've given you a lot of hard work, but this is Jamgon, the village. When I visited Jabalpur a long time ago, which you can see the sort of white man in the center, and then to the right is Beryl, my wife, who's the hematology technologist, and to the left side is Brigadier Tiwari, who was head of the Jabalpur unit at one stage. And then beyond him is Professor Bimal Kaur, who was so important in the development of information on sickle cell disease in India. So you've done very well. The last slide just says, congratulations on your work. I'm sorry we've had such difficulty, but this is always a problem with the internet in Jamaica, which they seem to shut down at the weekend to do maintenance. And I had an earlier program with India that worked fine, but unfortunately they've now switched it off. But thank you for your help, and I'm just sorry that we haven't had as much interaction as I would have liked normally. Thank you.
Sir, thank you so much that finally we could hear your important talk. Thank you so much, sir. And we will look forward for your visit to Jabalpur again.
Thank you so much, sir. Dr. Patra is not able to join for due to low connectivity, and he conveys his regards for this. Now I give the official vote of thanks to all. Dr. Raghunath. I invite Lieutenant Dr. Raghunath sir for closing remarks for this presentation.
Sir, can you please unmute yourself, sir? Sir, yes.
Okay, can you hear me now?
Yes, sir.
No. First and foremost, thank you very much for remembering me and calling me for this very nice symposium. And it was fairly exhaustive, and I learned a lot. I was associated with the very early baby steps of the sickle cell disease control mechanism. During the time that I was on the scientific advisory committee, we were doing the survey for this, and then I still remember we set up the electrophoresis setup in the department, and then got hold of the sickle cell, and then we not only did the electrophoresis, but the chromatography also at that point, and all those data started coming in at that time. I'm glad it has moved thereafter. We did take very preliminary steps of establishing a sickle cell disease treatment cell in the Jabalpur Medical College, which was given a fairly low priority, and therefore it used to get defunct very often. But at the same time, it did manage to get treat some patients, and some patients used to come from as far away as nearly 60 to 100 miles away from there, and it used to be heartrending to see that we couldn't really give them very much. We also looked at the mechanism by which we could make sure that the ambulance system and works over, and then we went on to the Madhya Pradesh government. At that time, the government changed, and thereafter you find that not much came out of it. However, I think, as somebody said, that you cannot stop an idea when the time has come. And I hope the time has come as far as sickle cell disease is concerned in India. And there is a lot that can be done. Unfortunately, or the trait and the disease is in the poorest part of the country. And those parts of the country which are very poorly um, serviced by the health services that are there. And this is one of the things that we need to uh, counter. But nevertheless, I think it is something that needs to be taken. There is the uh, talk on the governmental involvement on this. Um, which came in from the tribal side was very encouraging. I hope they certainly knew a fair amount of what is the problems of it, and to get this. During this symposium, we got to see the technology that is available, right from basic prevention of the severe symptoms using hydroxyurea and and nitrous oxide, and as well as immunization against pneumococcus and penicillin prophylaxis. I think even if we managed to do this particular point, we would probably be able to do a fair amount of benefit. We did do an estimation at that time to find out what is the life expectancy of a double S. And we were finding that the life expectancy was somewhere in the teens, actually, as opposed to the situation where anywhere else where there is good support, which should be around 60 years. That is the objective that we have as far as the disease is concerned. And it has, thank you very much. It's been a very good learning experience. And I'm very glad that you managed to put together a very nice program for on the sickle cell day. And I am hopeful that this will trigger off activity that at least I'm sure it will going to take a decade. By then, the next decade, most of our sickle cell disease patients will be served reasonably well. And as we said, we had also envisaged a situation where we could get bone marrow transplantation in Jabalpur Medical College, but I don't think it has taken off. Thank you very much, and thanks a lot for the opportunity to talk to you and be a part of the symposium.
Thank you, sir, for the kind words. Now, I feel honored and privileged to get an opportunity to propose a vote of thanks for this occasion. And I, on behalf of Director General ICMR and Director ICMR National Institute of Research, Jabalpur, and on my own behalf, I thanks to Dr. Nebendu Chatterjee, Scientist Staff and Head of the BMS Division of ICMR Headquarters for the inaugural address, and on behalf of the Director General ICMR. I convey my deep regards to and warm thanks to Dr. Sargent, who somehow steals his precious time from his busy schedule and graced the occasion. Although the connectivity was poor, but somehow he manages how to give a presentation and completed his presentation and given an excellent coverage on global perspective of sickle cell disease. He talks on various sickle cell disease population in Jamaica and Saudi Arabia, India and Greece, and how the disease phenotype is different in different countries. I be greatly encouraged by his gracious presence and immensely benefited by his inspiring address. My enormous respect to Sir Dr. Sargent, sir. And I must mention our deep sense of appreciation to Dr. Gurkan, sir. He has discussed various screening and diagnostic methods for sickle cell disease, and point of care devices is not need of our. As we see that there are most of the sickle cell disease is prevalent in tribal areas where the public health services and the trained technical staff is lacking and present. So accurate and point of care devices which is very useful for controlling the sickle cell disease. and Dr. Gurkan has explained very well how to the current point of care diagnosis techniques in sickle cell disease. Dr. Gurkan has guided in very interesting manner, and I thanks once again for his presentation. I would like to show gratitude to Dr. Patra, who spoke on epidemiology of sickle cell in India. However, due to network connectivity or poor, he is working very hard in remote areas at present. And although, but they somehow managed some talk on sickle cell disease epidemiology. I thanks to Dr. Patra sir. I would like to thank Dr. Mohanty ma'am, Dr. Jain ma'am, Dr. Seth ma'am for sharing their experiences for treating sickle cell disease patients, and they cover the recent advances in managing sickle cell disease in very short time, from the blood transfusion therapy to novel nitric oxide therapies and novel disease modifying agents such as renalizumab, voxelotor, L-Glutamine. And I'm sure that all of us learned that benefited from this, and participants from the clinical background will treat the patients well after listening the talk and implement the strategies that has been discussed in these presentations. I would like to thank special thanks to Dr. Raj Subraman sir for guiding me from time to time in the area of the sickle cell disease since I have joined this institute. He is my mentor, and he enlightened the audience on sickle cell disease in Indian tribes. What are their challenges for getting diagnosis and getting the treatment in tribal areas? And I also thanks to Mrs. Vinita Srivastava madam, who explained what are the national guidelines or policies which should be done for benefit of the sickle cell disease patients. And she told that there is a need for training of the public health services and nutrition, and she also told about how the nutrition and maternal health is important for treating the sickle cell disease patients. I thanks to Vinita Srivastava once again. I thank to Dr. Alok Srivastava sir, who has given wonderful talk on gene therapy and sickle cell disease patients. And in his very short period of time, he explained the need of the bone marrow transplant and need of the genetic therapy, gene therapy for sickle cell disease patient and thalassemia patient. He gave an overview of the gene therapy and what are the challenges currently in India for implementing the sickle cell disease, implementing the gene therapy for sickle cell disease patient. A big thanks to Dr. Alok Srivastava sir. I would like to thank Dr. Raghunath sir for giving his concluding remarks and the way forward for the treatment or research or epidemiological aspects, everything to be done when sickle cell disease patients. I again thanks to DG ICMR and Secretary DHR, Dr. Balram Bhargav sir, and also to the Director NIRTH for providing this financial support as well as the facility to conduct this event. And lastly, not least, but I would like to express my generous thanks to the Director for giving me opportunity to organize this event. He also guided me from time to time in every aspect of the academics, the research activities, writing proposals, manuscripts, and also it is his inspiration and guidance who motivated me to organize this event. He is ever ready to provide any type of help, and even in odd hours and when I needed in for organizing this event. A big thanks to Director sir. And lastly, no work is connected without the support of the administrative staff. So I would like to thank our administrative staff, our store section, our IT in charge, Mr. Abhinay, and I convey my regards to distinguished participants also from all over the world who joined this webinar in the late evening hours of the Saturday, and for their enthusiasm and participating in this event. I hope from all these presentations, the participants have learned a lot and take a home message to for the benefit of the sickle cell disease patients. Thank you also.
So with this, we are closing, and from my side, from ICMR-NITHR side, we thank everyone, all the speakers, all the participants, to show keen interest in not only the speakers, not only have put their views in a synthetic way, and then the participants also who have shown keen interest in this subject. So I wish everyone very good, very best of luck, and probably we will see again sometime with this kind of seminars. Thank you all.
I would like to add, we look forward to the proceedings of the symposium. It will make an excellent update on the subject.
We will, sir. We'll make a proceedings, and then we'll circulate to everyone, and hopefully we can be able to publish this so that every other one also can be benefited.
Yeah.
Thank you for this suggestion, sir.
Yeah.
Thank you. So we are signing off. Thank you all. A very good night to everyone.
Good night.